All right, welcome, guys. This is our first publicly viewed web episode. Again, my name is Timothy Yao. I'm one of the assistant professors here at Washington University in St. Louis. This is our first renal pathology teaching series. I am pleased to introduce our discussants today. We have Dr. Joseph Gaut, who is section head of renal pathology here at WashU, and Dr. Rajan, who is one of our renal fellows. So thanks for joining us, guys. I'm going to be walking you guys through this case here. So let's see if we can get started. Is the laser on the screen? Can you guys see okay?
Yes.
Okay, let's see how things go. So I'm going to present essentially a brief history, about as much information as Dr. Gaut would normally get when interpreting a biopsy. And Raj, your role will be to interpret the histology as we go through this. So the history you're given here is a 65-year-old Caucasian woman. She has a past medical history only of hyperlipidemia. She presents with acute onset swelling in her legs for 2 weeks. Creatinine is 1.1, albumin is 1.8, a urine protein to creatinine ratio of 8 grams per gram on spot, and you have no secondary workup at the time of biopsy. So based on this information, you want to run us through a quick differential of this case?
Yeah, given her presentation, we always want to think about nephrotic type diseases. This could include minimal change, membranous, of course, and FSGS, but other considerations, of course, would be diabetes or some sort of monoclonal gammopathy, amyloid. That should be sufficient.
Yeah, no, I think that's a great, as far as idiopathic glomerular disease, you named the big three, minimal change, FSGS, and membranous, and you don't have a history of diabetes, but let's go through the tissue and let's see what diagnosis this patient has. All right, Joe, I'm going to let you take over the mouse from here.
All right, very good. Well, Raj, why don't you walk through what we see here on first of all, what stain are we looking at here?
It looks, it's a light microscopy with a H&E type, H&E stain.
This actually looks like a PAS stain. You see that prominent brush border here.
Okay, yes, yeah.
On these proximal tubules, and this, you can see the outline of Bowman's capsule really nicely and the tubular basement membranes really nicely with this PAS stain. That's fine, go ahead.
So looking at the PAS stain, first of all, just looking at the interstitium/tubules. The tubules are back-to-back open, not so much debris. Maybe there's a little bit of debris right where you're pointing there, could be. I don't think it's proximal tubule. But other than that, looks relatively okay. I'm going to look at the glomerulus, and I don't see any significant sclerosis.
Okay. Well, let's first, before we hone in on those glomeruli, let's talk a little bit about your differential and what we would expect to see for those different diagnoses. So minimal change first, that's pretty straightforward.
Right. No, and over here, I'm not really seeing too many things that's kind of jumping at me to see other things. So yes, minimal change could definitely be in the differential.
Now, what about membranous? You had that in your differential.
So membranous, I'm going to be looking at a pattern where the basement membranes are thickened. Mm-hmm. Just comparing the tubular basement membrane to our glomerulus,
we'll want to do that more on higher power.
Yeah,
it's kind of hard to do that.
I'll give you some higher power images.
We'll get into that.
Okay.
And then what key diagnostic feature would you be looking at, particularly on the silver stain for membranous?
For membranous, of course, we'll be looking at the spikes, if possible, on the silver stain.
Very good. And you mentioned also focal segmental glomerulosclerosis. Now, what part of the kidney are we more likely to see a segmental scar, particularly early in the disease process? Cortex, corticomedullary junction, medulla.
Cortex.
At the corticomedullary junction is actually where those lesions first pop up. So if you only have a biopsy of cortex, you're less likely to appreciate one of those. And of course, it's dependent on how many glomeruli you sample because it is a focal lesion. All right.
Ready for the
go
next
ahead and
image?
move on.
All right,
Yes.
let's go on.
Okay, good. Now, what stain is this, Raj?
So this is an H&E.
This is the H&E. Very good. Excellent.
Numerous cells.
All right.
So again, looking from outside in, looking at the tubules, they're back-to-back open. There's not too much debris. I see the proximal tubule brush borders here and there.
Well, now it's hard to appreciate the brush border just on the H&E. It's very high power. You can appreciate it. However, it's best seen on that PAS stain where you have that thin sort of pink line that's highlighting the brush border on the PAS stain. But here I agree. The tubules are pretty much unremarkable. And they're
So
back to back,
inside
not
those
much
tubules, I
fibrosis.
wonder if that's just debris or is that like an ATN type process going on maybe?
Well,
maybe
was that in
not.
your differential? It sounds like the creatinine was relatively stable,
Yeah.
and
With minimal change, we can see they can
you
present
might
some degree of
there could be a little
ATN.
bit of cytoplasmic debris. When we see acute tubular injury, we would like to see more epithelial simplification of these tubules, where it looks very flat. There would be much more dilated. We might see actually
Keratosis.
dead cells in the tubular lumens here. And we don't really
You're
see
not
any
seeing
of
that
that. You
much.
can see some prominent nucleoli. We have one prominent nucleolus maybe right here, although it's difficult to appreciate on this power. You can see multinucleated cells as well. But
wonder if
really,
there's
these tubules look,
some-
for the most part, unremarkable.
Okay. Yeah. So now I'm going to head over to the glomerulus,
Okay.
and the capillaries are pretty much open. I don't see any areas of sclerosis anywhere. Looking at the cellularity, I think they're within normal. It's not more than 3 cells per field.
So when we talk about that, you're referring to the mesangium. So
Mesangium.
you're to define mesangial hypercellularity, more than 3 nuclei per little mesangial area. And here's a nice mesangial area I'm highlighting with the laser pointer. And yes, there's very few nuclei in this region. And you can see here maybe just 1 or 2, but for the most part, it's even hard to really appreciate much mesangium because it is not very expanded at all, and it's not hypercellular in any way, shape, or form. And the glomerular capillary loops, as you said, they're nice and open. It's hard to appreciate how thick these capillary loops are on the H&E stain. We traditionally compare them on the PAS
PAS
relative
stain,
to
right.
the proximal tubular basement membrane that's not atrophic. But for the most part, just appreciating this, they don't look terribly thickened compared to normal.
So, Raj, based on this is actually the last light image you have that I'm going to show you. If all the glomeruli look like this, which of your diagnoses could you exclude, assuming you had adequate sample?
I mean, definitely I don't see any FSGS.
Great. Okay.
Membranous, given that the base membranes are relatively thin, I would say it's less likely.
Okay. Good. I'm going to show you immunofluorescence now. Okay. So this is IgG. Negative.
Negative.
Okay.
Nothing
So based on this, which of the diagnoses can you exclude?
So besides the ones that I've already
Well,
excluded,
besides FSGS, you still have minimal change in membranous was kind of on the list. Can you have a negative IgG in?
no, not in membranous.
Great.
Correct.
Great. So that's the point. So you're left really now at this point
Minimal change.
thinking minimal change, and let's look at the EM to see if that's the case.
All right, so first, I want to orient yourself on the EM. So I'm going to point to some areas, and you tell me where we are. So right here, what is this?
So that's an RBC within a capillary loop.
Okay, well, we're in a capillary loop, but this is a nucleated cell. So
Nucleated
that is
cell.
not a red blood cell.
Right.
This is perhaps some type of monocyte or lymphocyte floating through the capillary lumen. Okay, so this is inside of the capillary loop, basically, correct? This here looks like an endothelial cell nucleus. Here's our lining the capillary loop. Now, what about out here?
Then we have the base membrane. Then we have the podocytes.
Right.
But there, I don't. The foot processes are fully effaced. I don't see it throughout if we follow it through.
Very good. You can't see, they're just completely fused, completely effaced here, where you cannot make out individual foot processes in this particular biopsy. And up here, just for completeness sake, this is the mesangium and a mesangial cell nucleus. All right.
Okay.
So I think we're ready to make a diagnosis.
Here's one more
well,
image.
we'll get
Just
another
a
one for-
close-up of the basement membrane, and
Okay.
I think this just highlights what you saw earlier, just at a higher power.
Excellent. So let's orient again. So what space is this?
That looks like the urinary
Yes.
space.
Very good.
And this is the capillary lumen.
Right, here's our fenestrae, which we can use. We don't have the foot processes really intact to help
Right.
us out here. So we can use this, however, this endothelial lining in their fenestrae. So again,
So there again, we have the effacement of the foot processes consistent with the minimal change.
Excellent. Yes. So minimal change disease is the diagnosis based on histology. It was on your differential based on the initial presentation. Now we're not going to, this is not meant to be comprehensive, just a quick blurb about minimal change disease, and we'll talk about the pathophysiology at other web episodes, but it is the leading cause of nephrotic syndrome in children. In fact, most children who present with nephrotic syndrome don't even get biopsied unless they don't respond to steroids. In adults like this patient, you should consider secondary causes, some of them being medication-induced. NSAIDs and lithium are common. Neoplasm, specifically the liquid tumors such as lymphoma and leukemia, and autoimmune diseases such as lupus can cause a lupus podocytopathy, which can lead to a similar histologic picture. So that was great. That was the first case. All right, second one, a similar presentation. We're going to go through it again in the same fashion. Here you have a 50-year-old African-American woman who comes in from an outside hospital for nephrotic syndrome and renal failure. She presented there initially with abdominal distension, which was found to be malignant ascites. They suspect an ovarian neoplasm, but this is not biopsy proven. Her creatinine on arrival is 2.2, which is up from a baseline of 1. Her albumin is low at 2.1, and she has a urine protein to creatinine ratio 12 grams per gram. So much of the differential that you gave me in the first case still applies here, but would you like to keep the same order, or would you like to reorder things based on this history?
Well, given her, there's this malignancy issue that's going on. I want to put membranous on top.
Okay.
And then also FSGS, given that significant amount of proteinuria, FSGS, definitely minimal change. And again, those would be, my top differentials here as well.
And you know, African-American race also bumps FSGS up a little bit higher. So same differentials. Let's go through these images.
So we have a trichrome stain.
Very good. Trichrome stain.
And the number of gloms we have over 7, so it's an adequate sample, of course.
All right, so what do we have up here? What's this piece of
Is that
fibrous-looking tissue?
scar tissue or fat?
This is the renal capsule
Capsule.
out here. All right, and here's renal cortex, and it looks like down here we're starting to get into some renal medulla. And we certainly have plenty of glomeruli. Now, to comment on the tubular interstitium here. So one thing that we love to use the trichrome for is to assess the degree of interstitial fibrosis and scarring. And so is there a lot of chronicity to this?
Well, no. I mean, they're not too much. Not something that I would I would say
No, there's very little. The tubules look back to back as far as you can tell from this power. You don't see any globally sclerosed glomeruli, correct? I mean, these are all intact, at least from what we're seeing at this viewpoint. So it looks like it's fairly, there isn't a lot of chronic damage at this point.
Okay.
All right.
Let's go on to this image.
Okay, so what stain are we looking at here, Raj?
So this looks like a PAS stain to me.
This is the H&E. Okay,
And
so it's a little more
Nice try, though.
that eosinophilic color, and it almost has an orange reddish glow and with the bright blue nuclei. So this is back to our H&E,
Okay.
and we obviously have the glomerulus in the center of the field.
Right. So I'm just looking at the glomerulus. It tells I see that the membranes are pretty thick, I would say, and there's maybe some mesangial expansion there. The capillaries are open throughout, but there's some areas where it seems like it might be closed. Looking at the cellularity, I would not call this hypercellular again, but again, there are some areas we can say there's more than 3 cells here and there.
A few here and there.
But overall, I wouldn't say it's not significantly.
Clearly, the major
cellular.
finding is this thickening
Thickened
of the
membrane.
capillary loops. At this point, it's hard to appreciate what all of that is composed of the basement membrane, but certainly we do have thickening of the capillary loops. Ideally, we'd like to look at this on the PAS and compare this to the adjacent tubular basement membranes that are not atrophic, but just looking at this, they appear somewhat thickened. Certainly, thinking back to the case before, this looks quite different.
Definitely.
I'll show you a PS next, so you can see the difference between the H&E and the PS stain. I like to look at the tubular basement membrane, and you'll compare them to the glomerular basement membrane here now.
So, and you want to look out at a peripheral capillary loop. Don't look buried here in the center of the glomerulus. Look at something out here on the periphery, such as here, or even up here. We have this is a nice one here. We're relatively close to some basement membranes of these adjacent tubules.
Right, and definitely there's they're thickened compared to the tubules.
Like look at this one and compare here. That's at
Oh,
least
yes.
2, 3, 4 times as thick. So there is diffuse, or there's and global thickening of the glomerular capillary loops. And then again, looking at the tubules, here's our nice brush border,
Right.
highlighted on this PAS stain, and they're
relatively
relatively
back to back, and I don't see anything.
exactly. There's not much going on. There's no inflammation. There's no significant fibrosis. And the tubules look pretty unremarkable.
Okay, I'm going to give you a silver.
So, looking at the silver stain, we could see the little spikes Oh yes.
Yes. Yeah.
Oh,
Yes, there are these little bumps almost that appear. And you want to, again, look out here at the periphery of the capillary loops. It's where it's easier to spot these things. So you can see them as these little bumps. Now, what does that actually correspond to?
So those are the deposits and then areas of our base membrane. So
Now, what is the silver staining? Is it staining the deposit or is it staining the basement membrane?
the basement membrane.
Exactly. So those little spikes are the basement membrane that sticks up in between the immune complex deposits in patients with membranous. Now, you can imagine if you took one of these capillary loops and flipped it and looked at it from the top down, what you're going to see are a bunch of little holes. So sometimes these will be referred to as pinholes. I don't see really good. Maybe perhaps down here we're getting a section like that where you can see these pinholes in addition to the spikes. It all just depends on the orientation that we're looking at these.
Okay. And so this looks like membranous. If you are looking at immunofluorescence, what would you expect to see in membranous, Raj?
Well, good question. If it's idiopathic, I would say
Great,
IgG4.
okay. Okay, right. And if it was, let's say, lupus?
Then the others. But
The others being IgM, IgA,
Yes.
C3, C4, full house, right?
full house pattern. Right?
Okay, good. All right, so here is IgG. This is not a specific IgG4 stain,
Mm-hmm.
but it's obviously
It's
positive
diffuse, yeah.
in the glomeruli, right?
And it's staining here also the capillary loops, and it's kind of a granular pattern staining all over the capillary loops and all of these glomeruli.
Here's a closer up view of that. I think
Here we
this is
go.
a
That's
nice
much
picture.
better.
Mm-hmm.
Okay.
So you can appreciate the granularity here
Yes.
much better, and it really is staying in the capillary loops.
All
Now
right.
the IgG4, would that be in the subepithelial area, or would it be all throughout the capillary loops?
So that would be it would stain with the IgG, the exact same distribution, because that would be the subtype of immunoglobulin that is staining in predominantly in cases of idiopathic primary membranous. So it would stain again in the capillary loops, just like this.
And if you had staining for PLA2R, it would also be
The same.
Right, PLA2R, another marker that we can use to just help distinguish primary versus secondary.
okay. So I'm gonna just breeze through this. This is IgA, essentially negative, at least compared to the IgG. IgM maybe slightly positive, but overall, if you compare the intensity, it's nothing like the IgG was. All right, and so I'm gonna give you EM, and you can tell me what you see and where you see something abnormal.
All right, so let's just get the pointer out to help everyone figure out where we're talking here. So
we have the
what
red
is
blood
this?
cell.
That's the red blood cell. Very good. So we are,
And
what
the
is this space?
capillary.
Capillary loop. And out here,
And that would be the urinary space.
urinary space out here. So this is our glomerular basement membrane.
Mm-hmm.
And what do you
definitely
see?
see those deposits. So that would correlate to the little spikes on the
So these things here
the area. Yes, the base membrane itself.
are the spikes.
Spikes, exactly.
These projections of the basement membrane in between these electron-dense deposits right here. And what location do we?
The subepithelial.
These are subepithelial
Deposits.
electron-dense deposits. Very good. So that's typical. So what else are we seeing here? What about the podocyte foot processes?
Well, they don't look good.
They don't look good at all. I
They're
mean, where are they?
effaced.
Right? Yeah,
Yeah.
that's good. Go with your instinct. Right? Yes, they're gone. They're effaced. Again, here as well. So does that mean this is minimal change on top of membranous?
No,
No. Very good.
it's members. And then, well, would you say if it's diffusely effaced versus just certain areas, would that correlate with like idiopathic versus
No.
secondary? Or no, not really.
No, our tools are limited to distinguish primary versus secondary membranous. Now, of course, if you have full house staining and the patient has a positive ANA and a double-stranded DNA and all features of lupus,
Or mesangial deposits.
and if they have the deposits in other locations, such as in the mesangium and subendothelial deposits, then you're really thinking this is lupus.
Right.
However, the other tools we have, such as PLA2R staining, which certainly is positive in many cases, but it's not 100% positive, and it certainly can be positive in cases of secondaries. Same with IgG4, but they certainly favor a primary process versus a secondary membranous. So those are the tools that we have at our disposal.
Here's just a higher power EM. Again, you are in yourself.
Yeah, again, the same thing. We have the RBC and the capillary, and the fenestrations and the basement membrane, and then we have those deposits in the subepithelial region under the foot. It's supposed to be under the foot processes type.
Well.
Supposed to be.
Right here. So here they are. Yep, subepithelial electron-dense deposits with the spikes of normal basement membrane sticking up in between.
Yeah, this is a really great picture to really see how the silver and ends up with spikes, because you can just see, if you eliminate those deposits, how you see the spikes on the collagen stain. All right, so your diagnosis.
And this is membranous, and I suspect could be related to the cancer, maybe, but we can't say for sure unless I get more stains.
Right. So, and that's difficult to differentiate. I mean, so membranous is a common cause of idiopathic nephrotic syndrome in adults, whereas again in children it was usually minimal change disease. And as you mentioned, there are secondary causes. In this case, the ovarian cancer or suspected ovarian cancer. Other secondary causes include classified lupus. And you mentioned the full house staining that is usually accompanied with that. Infections such as Hep B, Hep C and HIV as well, but Hep B is the one that's typically seen. And malignancies, again, as opposed to minimal change disease, which is usually seen with the liquid tumors such as leukemia and lymphoma, membranous is typically associated with solid tumors such as the GI tract, lung, and prostate. So that wraps up our first episode. Great work, Raj. Thank you again, Joe, for doing this. So please subscribe to our YouTube channel. Follow us at WashU Nephrology. If you have questions about the case, feel free to email me. My email is here. Or leave a comment in the section. Follow me on Twitter on the handle there. I want to thank Dr. Cymbaluk, who's the nepropathologist up at Rush, where I did my fellowship, for providing me with these images and teaching me about renal histology so that I could teach these guys about it. Sponsors, Renal Fellow Network, AJKD blog, Nephron Power, Nephrology Journal Club. Follow them at their links there, and we will see you guys next time. Thanks, guys.